All right. Hi, everyone. This is the lecture for chapter 32, which, oops, I don't know why I did that. Sorry. Which you can see is focused on pain. And we'll talk about neuropathy and headache, and we'll talk about other pain disorders as well. I'm not sure why this isn't. There we go. Sorry. All right, so let's get started. And by the way, I definitely am not covering everything that's in the chapter. So make sure, obviously you're listening to this recorded lecture. Only what I cover is what you're responsible for. So just to define pain, right? And what we mean by pain, I'm sure we all know what pain is, right? But if you want to define it, unpleasant sensory and emotional experience. It can be associated with like actual tissue damage, but also potential tissue damage as well. It can be subjective, right? And so there is a sort of psychological component of pain, okay? And we're not going to talk too much about that, but definitely subjective, right? People are going to rate, two people that sustain maybe the same exact injury. One might say that their pain is a 9 out of 10 when another one might say 6 out of 10. Okay, so that's kind of what we mean by subjective. And obviously that suggests that it's affected by numerous factors, right? There are many, many environmental factors and even just like stress, other types of diseases that will affect pain, okay? In terms of, you could talk about pain as a symptom, right? Pain as a symptom from injury, right? Or other types of diseases. Or you can talk about pain itself when we're talking about neuropathic pain. And we'll talk about that a little bit more towards the end of the chapter. Okay. So a little basic, honestly, we're really not going through the neuroanatomy of pain, like a tiny bit. Okay. So we're just going to kind of scratch the surface just to give a little bit of basic sort of biology about this. Okay. And you'll see if you look in the textbook, there are a bunch of different figures kind of involving this. And I'm really just kind of pulling one of those and I added a few things to it. So again, you're only responsible for what I'm presenting here. So a few things, right? So if we talk about nociceptive pain or nociception, these are going to, or nociceptors, these are receptors that are going to be, they're going to detect things like heat, cold, right? Vibration, stretch. And so if you even think about, receptors in the skin, okay? Those obviously are there to detect heat and cold. Again, pressure, right? Stretch. Also in your muscles, there are stretch receptors. Okay. So, anyway, there are various types of receptors and these are all involved in, taking in that stimuli and that pain signal essentially. Okay. Also, you can have chemicals released from damaged cells that can activate these receptors as well. So kind of what's listed here are sort of different types of stimuli that can activate these pain receptors, okay? If you talk about neuropathic pain, like I said, we'll talk about that towards the end of the chapter. This is where you actually have nerve cell or neuron dysfunction, either in the peripheral nervous system, right? Or the central nervous system. And also it could be both. Okay. So when we're talking about central nervous system, we're talking about the brain and the spinal cord. If we're talking about peripheral nervous system, we're talking about anything outside of that, right? So we're talking about those nerve cells that are in the nerves in the periphery. You can also categorize nociceptive pain based on somatic pain and visceral pain, right? So visceral pain refers to sort of deep pain that's stemming from your organs essentially, okay? Whereas somatic pain is, say pain that you feel on the surface of your skin or in a limb or something like that, okay? All right. Again, kind of a few other ways to categorize pain: acute pain versus chronic pain, okay? So acute pain says lasts hours to weeks. And it is really associated with some sort of injury, right? Acute tissue damage or trauma, surgery, right? That pain really can be attributed to that sort of one specific thing. And you can see though, sometimes it might be hours, but you could still consider acute pain as lasting weeks, okay? There could be some disease process that's inducing this acute pain. It could just be, again, some sort of inflammation that could be triggered by a disease process, or it could be triggered by surgery, by injury, or what have you, okay? But inflammation itself can trigger pain, okay? If you talk about chronic pain, that's going to persist for months or years, right? And in general, and in some cases, it sort of increases with intensity as that chronic pain persists, okay? Can be associated, it says here, with a resolution of an acute injury or inflammation. So there is some acute injury, maybe you had acute pain, but for whatever reason, that pain really persists, okay? And then there are also chronic diseases that lead to chronic pain. And again, we'll talk about some of those towards the end of the chapter. Okay, so if we talk a little bit about kind of like how pain is sort of, painful stimuli come in, right? Come in through these nociceptors, right? And again, these are sort of specialized, these are nerve endings, right? These are neurons, and on one end they have these receptors on them, these pain receptors, okay? And then that signal is going to be sent into the central nervous system, okay? So let's talk a little bit about that. So you can kind of divide that up, right? You can talk about pain transduction, okay? So it says conversion of the noxious stimulus into a nerve impulse. So that's just what I said, right? On the ends of these nerves, right? Again, these are sort of specialized sort of neurons, but anyway, on the ends, these sensory neurons, right? On the ends are receptors, okay? And there are pain receptors there. There are also other types of receptors. You know, we kind of talked about heat and cold. There are some different types of receptors. So different receptors will perceive something as just hot, like temperature hot, versus painful hot. Okay, so what we're really talking about here is pain. And again, we're not even going to get into those different types of receptors or anything like that. Okay, so anyway, you're going to have conversion of that stimuli, whatever it might be, into a nerve impulse, right? That nerve impulse then is going to be sent along that axon. Okay, and like I said, it's going to get transferred to the central nervous system. So you call that pain transmission, right? So now it's in the central nervous system, in the spinal cord, right? If you're talking about something coming in, say, from the finger, right? It's going to go into the spinal cord first and then make its way up to the brain, right? And so that's where the modulation is going to occur. So it says peripheral and central neurotransmitters that enhance or dampen transduction and transmission of the noxious stimulus. So definitely modulation, super complicated, okay? You can think of, there's neurotransmitters involved like norepinephrine. You can think about the opioids here, right? You have an endogenous opioid system where there are endogenous opioids like endorphin, right? And their receptors, and they're going to be involved in modulation. But there's also other neurotransmitters that are involved in modulation as well, okay? So these will sort of change how that pain is perceived, right? They could enhance or they could really suppress that pain that's actually felt, okay? So again, super complicated. We're really not going to get into it too much, but I want you guys to understand that there is a lot of modulation of pain that will go on. And you can see if you have an issue with the way pain is modulated, it can then greatly increase your experience with pain, okay? So it's not just a sort of, cut and dry kind of the painful stimuli just comes in and then that's it, you feel pain, right? There's a lot of processing and modulation that goes around that, okay? And so then again, finally, you're going to have perception, kind of like I said, right? So this is kind of what you now perceive, right? How much pain do you feel and what does that sort of mean to you, okay? And so again, like we said, there are many influences that sort of come into play here, okay? So again, we talked about pain transduction, transmission, modulation, and then perception, okay? And obviously, if we're talking about cognitive or cognitive appreciation or cognition, this is going to involve different brain areas, right? And really complex sort of mechanisms that are going to go on in the brain. Okay, so I mentioned this already, right? Nociceptors, those are what are going to sense those stimuli, those painful stimuli, okay? So it says transduction of noxious stimulus to the nerve impulse. That noxious stimulus comes in through those nociceptors. It then turns into a nerve impulse, right? It generates an action potential and it's moved along that axon, okay? And as I mentioned before, it can be somatic or visceral. Again, visceral is going to pertain to the internal organs, okay? Whenever you're going to have the nociceptors be activated, right, and generate an action potential, that will, what happens is that membrane becomes depolarized, right? And you can generate an action potential. What can happen is that you can have upregulation of calcium channels in these nociceptors, and that actually can lead to things like hyperalgesia and allodynia. And the idea is that these neurons become, their membrane potential becomes affected, okay? And they basically become closer to generating an action potential. And so in this case, whenever a painful stimuli might come in, right, it's going to increase that response essentially, okay? And so that's how it can lead to hyperalgesia and allodynia. These terms will kind of come up again later on. So this is basically enhanced perception of pain, right? Hyperalgesia. And then allodynia is the feeling something that's not normally painful would be felt as painful. Now I know I defined some of these later on, so yeah, so don't worry about that right now if you didn't get those definitions, okay? But you know, you can always obviously kind of quickly go back and look them up, but those will come up again later on, okay? And there's actually one slide where I sort of ask you to go back and look up those definitions and make sure you have them. And I also think I added some in, okay? So anyway, let's make sure by the end of this lecture, we're clear on what these terms mean, okay? All right, so I mentioned, well, okay, so it says here, endogenous inflammatory chemical mediators. So again, we mentioned inflammation as being able to trigger pain, right? So it says here, inflammation or trauma-triggered changes in the environment of the nociceptor. So inflammation that's going on around these receptors can also sort of activate them, right? And that will then lead to pain. So it says here, inflammatory soup increases excitability and sensitivity of these nociceptors, okay? So again, a whole bunch of inflammatory molecules around these nociceptors will make them more active, right? Will increase their excitability and then will lead to more pain, right? So these are both kind of two mechanisms that can increase pain per se, right? And really activate these nociceptors. So bottom line is when these receptors, these nociceptors become activated, those signals get sent into the central nervous system and those are pain signals, okay? These two things actually make those nociceptors more active and basically would cause more pain, okay? All right, if you also want to, if you talk about, this is talking about the periphery, again, things that can increase pain sensitivity, right? So these are another sort of mechanism is sort of continued from here, okay? So it says substance P, glutamate, these substances and glutamate's technically, considered a neurotransmitter, will actually directly activate nociceptors, okay? And so these types of molecules can be released from injured tissue. And again, if they activate the nociceptors, then they're going to lead to pain, okay? There are other types of substances that are released by damaged cells as well, like prostaglandins, histamine, right? We mentioned these in our inflammation chapter, okay? And these will also activate these nociceptors and cause pain, okay? Again, just a little bit more terminology too. So here it says peripheral sensitization. So again, increased sensitivity of pain. The presence of these molecules will sensitize these nociceptors so that there's more of these stimuli being sent into the central nervous system. And again, the patient is going to feel more pain. If we say primary hyperalgesia, we saw hyperalgesia on the last slide, right? It's exaggerated or prolonged response to pain. Okay. So when these inflammatory molecules and these substances that are released by damaged cells are around to activate these nociceptors, they will lead to peripheral sensitization, which will essentially is an increased sensitivity of pain, and then will lead to this exaggerated or prolonged response to pain. Okay. So really all three of these, right? 1, 2, 3 things that were listed here are all ways in which, or all mechanisms, I guess, or things that will enhance or increase pain. Okay. So those were kind of 3 different, like I said, 3 different ways that sort of pain is increased. Okay. So the other thing is, and I'm going to show you a picture here too, and I already kind of talked about this, but I'll bring this back when I show you the picture. What I've been talking about, right, is activation of these nociceptors, sending information into the central nervous system, right? And then that goes up to the brain eventually, and you feel pain, okay? there are also descending tracks or pathways, okay? And when we say descending, we're talking about from the brain going down through the spinal cord and then out to the periphery that will inhibit pain, okay? So these are modulatory pathways. And so, again, there are different inhibitory neurotransmitters like GABA and other peptides, particularly you think about opioids here, they are involved in these descending pathways, okay? So when I show you the figure, like I said, I'll point that out again, but let's understand that that's involved in as well, okay? Also, glial cells, which are the supporting cells of the central nervous system, right? Remember, you have neurons that actually send the signals, and then you have glial cells that support those neurons. They can be involved in pain as well because they release cytokines, they can release glutamate, they can release nitric oxide, all of which can activate nociceptors, okay? And so these can cause central pain, they can cause sensitization. So when we talk about central pain or central sensitization, we're talking about within the central nervous system, right? That these glial cells can kind of induce these neurons to become activated, all right? And so again, it says here also damage to neurons can affect excitability as well. So the point is this is kind of the idea that glial cells can also sort of, like I said, cause these nociceptors to become active, okay? And lead to sensitization. What we're talking about here, when it says peripheral sensitization, that means in the periphery, okay? So outside the central nervous system that this can happen. But this idea here is inside the central nervous system, okay? Neurons that exist inside the brain of their spinal cord becoming sensitized and then therefore increasing the painful experience. All right. So like I said, what I did there, if you look in the textbook, there are a whole bunch of different figures that kind of break it down, just kind of trying to focus on the transduction, then focusing on the transmission and focusing on the modulation. Again, I want you guys just to kind of understand this in general. I think this figure is pretty important. So I sort of added a few things in here that I was talking about along the way. Okay. So again, here, right, here's your noxious stimulus. I don't know, touching a match, right? And so obviously if you directly touch fire, it's going to be painful. Okay. So these nociceptors, right, become activated. Okay. That nerve impulse gets sent along here. And it's going to end up going into the spinal cord here, okay? This is kind of showing you that at this point, you do have some opioid receptors here as well. At this point, there's going to be opioids that are involved because you're going to have some modulation that's going on inside that central nervous system, okay? Here, again, you have essentially a synapse that's going to occur. Don't worry about that. But, okay, we just want to understand, here's your nociceptors here that are basically detecting this painful stimuli. That information gets sent in, right, into the spinal cord first, okay? And so again, and then once it gets here, so here's the transduction, right? The noxious stimuli being transduced into a nerve impulse, right? Action potential. And then transmission, it's being transmitted into the central nervous system, okay, into the spinal cord. And then here it's going to be modulated, okay? In fact, actually here, I don't think you technically have a synapse here, but the cell body is sitting here. So don't worry about this, but I just want you guys to understand that. Let me double check that. Yeah, I don't think there's a synapse there. But like I said, that's beyond the scope of this class, so I shouldn't even have said that word. Just understand that opioid receptors and opioids, endogenous opioids, like I mentioned, like endorphin, are involved in this process kind of at various different points. Okay, we'll leave it at that. One of the places they're involved is in modulation. Okay, so once it gets to the spinal cord, there's some modulation that goes on here. Okay, and it involves these types of peptides here, GABA, opioids, somatostatin. These are in general inhibitory, okay? And so they can help and sort of dampen the response so that it isn't as painful, okay? So if this modulation, say, doesn't occur, then again, that would be experienced as more painful. All right, so anyway, you got this information coming into the spinal cord. It ultimately crosses onto the other side, and then it ascends up into the brain, okay? And if you're thinking about perception, right, we said kind of now the perception part of it is, all right, how does that pain feel to you, okay? It's influenced by a lot of things, right? Emotion, psychological stress, culture, religious beliefs, prior experience. All of these things are going to shape your perception of pain, okay? And also, like I mentioned, there are descending pathways, okay? So when we say descending, that means brain down, meaning there's pathways that come from the brain down that then basically modulate this painful experience. And again, most of the time, these are inhibitory as well. And so if there is some issue with these descending pathways and the inhibition of pain, it's going to lead to more pain. Okay? So again, I'm not showing you the descending pathways. That's beyond the scope of this class, but understand that there are also pathways that come down to modulate the feeling of pain. All right? So again, just like most of these, chapters and things that we're talking about, complex, okay? There are many, many different parts or different things involved in the perception of pain, okay? All right, so now let's talk a little bit about acute pain, okay, specifically. So sudden onset associated with acute or potential trauma to somatic or visceral tissue. Again, visceral organs, okay? If we talk about somatic pain, and we mentioned somatic a few times before, skin, soft tissues, ligaments, right? Skeletal muscles, bones, joints, that's all somatic pain. Again, visceral pain pertaining to the organs, organ inflammation, right? Spasm, dilation, mechanical obstruction, impaired blood supply. All of these things are going to cause visceral pain. And there are receptors that are around that can detect this visceral pain, okay? One thing with visceral pain is that it's not usually felt directly where it's happening, right? So it says here, pain frequently referred to distant site due to visceral and somatic conversion in the dorsal horn. You don't really need to know why, but there's something called referred pain, which is obviously super important clinically, right? In terms of like if there's some sort of ischemia going on in the heart, right? The patient may not feel that pain right over that spot, okay? Maybe the pain's in the jaw, or maybe it's down the arm, okay? But there are also other types of referred pain that I'm sure you guys will learn about clinically in terms of, again, if a patient is complaining of pain in a certain area, you should be tuned into that to say, oh, that might be, say, coming from, the small intestine or the stomach or the heart. Okay, so that's what this is referring to. And again, we're not going to get into that. In terms of treatment, okay, multimodal pain management, use of 2 or more agents with different mechanisms of action is usually most effective. And there's this sort of World Health Organization's 3-step analgesic ladder. The idea is we're not going to give opioids right away. You start with non-opioids, right? Non-steroidal anti-inflammatories, right? Like ibuprofen and aspirin. If those then don't work, maybe you then move on to a weak opioid like codeine, and then maybe a stronger one if necessary, okay? There is something called patient-controlled analgesia, and it allows patients to administer their own medication. And usually, you think about this with morphine, and this is probably in cases where there's severe pain going on. Maybe these are cancer patients that are close to the end of life, and they might be able to administer their own morphine, depending on right, to keep themselves comfortable. All right. So like I said, I'm shaving off, some stuff from this chapter. So we move on. Now we talk about chronic pain. Remember that it lasts longer than 12 weeks. And it says, or longer than expected for healing to take place. So the idea is if you have a certain injury, or a surgery or something like that, if that pain is lasting longer than really what the clinician expects for the healing process, then we may then categorize that as chronic pain, okay? So there's sort of 3 main categories here: chronic recurrent pain, chronic intractable benign pain, and chronic progressive pain, okay? And I guess I'm not really going to get into those different categories. So, just know that you can sort of categorize it this way. But again, I'm not going to ask you really about these too much. Okay. So we just want to know really what's chronic pain. How is it different than acute pain, right? It says goal of chronic pain management, pain reduction, obviously, and improved quality of life. Okay. And maybe to try to get at, and I think maybe this is brought up a little bit later on, but if there's chronic pain going on, it could be influenced by stress. It could be influenced by some other, some other sort of issue going on, maybe stress, anxiety, right? Depression. And so these might be things that you might want to try to address. Okay. All right. So now let's talk about neuropathic pain. I mentioned this at the beginning of the chapter as well. So if we talk about neuropathic pain, we're saying there's damage to the peripheral nervous system or the central nervous system. Okay, so it's not caused by inflammation or inflammatory molecules surrounding the nociceptors or things like that. It's actual damage to the nerve, essentially. Okay, so you can have, so there's a couple of different things that can happen. Neuritis is defined as inflammation of a nerve, right? So the nerve itself can become inflamed. That can then generate pain. If you talk about neuralgia, this is the term for pain that basically follows the distribution of that nerve. So for instance, if that nerve is inflamed, you may have pain that follows that nerve. Okay. And again, if you're describing the location of your pain to a clinician, they should be able to figure out kind of where that's coming from, right? And then obviously look into further testing to see what's going on. If you talk about radiculopathy, this is going to be pain or the loss of sensory motor function due to impaired conduction in a spinal nerve or its roots. Okay, so like, i.e., a pinched nerve. Okay, something's impinging on that nerve. I don't know. Maybe it's an injury that did that. Maybe it's a compressed disc or something like that that's pinching on that nerve. And so that's what this is, kind of speaking to here. And that would cause pain. It can cause pain. It can also cause the loss of sensation, like it's saying here, loss of motor function. So narrowing of the space where the nerve roots exit the spine, right? So stenosis, that's what stenosis is. I have that in my cervical spine. A lot of people have it in their lumbar spine, but you get narrowing of that space, and basically that can compress on that nerve root, okay? And depending on how severe it is, it can lead to, severe deficits. But a lot of people have that. Sciatica is, again, this is more down towards the lumbar part of the spine, right? And that sciatic nerve travels down the leg, and so you sort of have this characteristic kind of pain that moves down that leg. Okay, same thing though. It's sort of compression and impingement on that nerve. Okay, if you talk about neuropathy, this is dysfunction of the nerve fibers. There's some sort of dysfunction of in the peripheral nervous system, again, and or the central nervous system in terms of those nerve fibers. Okay. Again, if you talk about peripheral neuropathy, again, this is in the peripheral nervous system. About 20 million people in the United States apparently suffer from peripheral neuropathy, and it's described as sort of this burning or aching sensation of the limb. Okay, so what is neuropathic pain associated with? So a lot of times associated with traumatic injuries or surgical procedures, and so things that would actually partially or completely sever, crush, compress, or stretch a peripheral nerve, right? So again, we said it's damage to a peripheral nerve, or some inflammation to a nerve, right? Says here, repetitive stress leading to nerve entrapment. Okay, so again, anything that's sort of affecting that nerve. Metabolic endocrine disorders can cause neuropathic pain, like diabetes, chemotherapeutic agents, radiation. Okay, you see that a lot with chemotherapy. Infections, nutritional deficiencies, heavy alcohol consumption, and also environmental exposures to like lead, mercury, and arsenic can actually lead to nerve damage, right? So really anything that can lead to some sort of damage to a nerve, right, can then lead to neuropathic pain. Sometimes you don't really know even what's causing that neuropathic pain, okay? Or it's hard to identify what triggered that neuropathic pain, okay? So that's what this is saying here. Maybe there is no obvious tissue injury or disease, and if the patient is just experiencing this neuropathic pain, okay? So there are many things that could be directly linked to neuropathic pain, but there are also many cases where you don't really know what's causing it, okay? It says serves no protective biological function. Yeah, so nobody can really, figure out why this would be sort of what happens. here's where I was just mentioning looking up terms. I guess I didn't just mention that. I mentioned that at the beginning, right? These are clinical manifestations. These are all medical terms, okay? So you guys can look up. I defined a couple for you, but look up these, right? Make sure you know what is meant by these medical terms, okay? So make sure on your review sheet you're adding the definitions in. So the couple that I added in for you, allodynia, and I think I talked about allodynia before. It is the experience of pain from a stimuli that is not normally painful, okay? So something that would not normally cause pain causes pain, okay? Hypoalgesia is decreased sensitivity to a painful stimuli, okay? All right. In terms of treatment, right? It says multidisciplinary pain management team. In general, so there's kind of, again, when we're thinking about multidisciplinary, the idea is that there are many different factors that sort of can contribute to this. So it might mean it's physical therapy, it's psychiatry, right? It's all these things. Maybe it's just stress reduction, things like that. In general, neuropathic pain does not respond well to opioids, okay? So those are generally not used to treat it. Sometimes they are, as you can see down here, but in general, they're not very effective, okay? So a lot of the treatments that are used are antidepressants, anticonvulsants. Anticonvulsants are going to increase GABA. GABA is inhibitory, okay? Cannabinoids. THC is effective in treating pain, and particularly in neuropathic pain, okay? There are also some topical medications, acupuncture, massage, those all can help as well. So I think you kind of can see that it's a little difficult to treat, right? Antidepressants are going to increase serotonin, and that helps with this as well, okay? If you talk specifically about diabetic peripheral neuropathy, right? We said, neuropathic pain can be caused by endocrine disorders like diabetes. If you want to specifically talk about diabetic peripheral neuropathy or DPN, okay, in terms of the pathogenesis, what's causing it? It is, if you're talking about a microvascular issue, okay, where high blood glucose and decreased blood flow is going to affect the capillaries, right? And also, so lead to things like ischemia, right? So if you get damage, right, to that microvascular system, obviously you can't deliver nutrients and oxygen to that area, okay? And that's going to affect the nerve fibers, okay? So you can basically lose nerve fibers due to this ischemia that's induced by diabetes, okay? And then that can lead to nociceptors to be sensitized, and then also additional nerve fiber damage. So all of this, in terms of the damage to the nerve fibers or loss to the nerve fibers, leads to an increase in pain, okay? So in terms of clinical manifestations, symmetric pain, right? I defined one of these, I think that were on the other slide. Paresthesia, which is numbness, tingling, or a prickling sensation. In terms of treatment, tricyclic, as we talked about tricyclics before, they inhibit the transmission of the nerve impulse, okay? So we talked about tricyclics when we talked about depression and anxiety, okay? You can see that there's some of these same drugs are even used to treat pain. Again, anticonvulsants in general will increase GABA or prevent the release of excitatory neurotransmitters like glutamate, and that will help decrease activity and sort of inhibit, okay? Capsaicin cream or spray is also another type of topical treatment that can be used. There's also electrical stimulation that can be used. So there's something called this TENS unit, transcutaneous electrical nerve stimulation, which will actually activate cutaneous sensory fibers and will cause the release of inhibitory neurotransmitters to, again, help decrease the activity of those neurons and decrease the activity of those nociceptors and try to suppress that sort of, transduction of pain, okay? Also, you can add electrodes into the epidural space in the spinal cord, right? That can help reduce the activity of those nerves as well, okay? Another type of pain, phantom limb pain, PLP. Okay, so this is pain that's following the loss of a limb. You can have something called stump pain. So this is really acute nociceptive pain at the site of where the amputation occurred. Also, there's things called phantom sensations, right? So it's not pain, but you have these other sort of sensations in where that missing body part was. Something called telescoping, where there's a sensation that distal part of the missing limb is basically gradually approaching the limb stump, right? Kind of something weird to think about. But then you can also actually have pain that is perceived as coming from where that amputated limb was, right? So it feels like the pain is coming from where that part of the arm was, okay? The stump pain is actually coming from the end of where the amputation occurred. The phantom limb pain is originating from where that limb used to be, okay? In terms of etiology and pathogenesis, it says here peripheral and central neuroplasticity. So when we talk about plasticity, we're talking about kind of sort of you can think of sort of remapping, and it says it down here, right? Well, first of all, if you're talking about neuroplasticity, it's the idea that if there's a lost nerve or damaged nerve, another nerve will kind of pick up and detect sensations from that lost nerve, okay? So that's kind of the idea, that there's sort of this compensation of the nerves that are still functioning for the ones that are lost, right, due to that amputation. And so they'll be sort of picking up more distant signals, and that's why you get this sort of weird perception of where the pain is coming from, okay? Also, ectopic discharges, that's basically just from, again, those kind of think about if a nerve was cut off, right, that was going to extend through that amputated limb. If there's basically just discharges of neurotransmitter that's happening in that nerve and that axon becoming, or that neuron becoming activated, that can cause this as well. Okay, peripheral nerve injury, kind of said that already. And then it says here, maladaptive cortical plasticity. Again, I'm trying to kind of not get too detailed here, but what can happen, again, if whenever your sensory information is coming in from the periphery into the central nervous system, right? If you think in your cortex, there is a sensory cortex, right? That sensory cortex, parts of it correspond to different parts of the body. So if you're missing some fingers, say, that cortex area of your brain will actually, again, go through some plasticity where the part of the brain that was for, say, your pointer finger and your thumb, it'll sort of be taken over by the area of these other three fingers. So it's not like that part of the cortex is going to go away, but it's like you're going to sort of perceive or have increased sort of sensation from where that was. Okay, again, I don't even know that I should have went through that, but I think it's worth us understanding that, you can have neuroplasticity that's happening actually in the brain that can affect this sort of experience of pain. Okay. It says, for clinical manifestations, rapid onset. It could occur right after that amputation happens, but then it can also last a lot. It can last long, and you don't really know how long this is going to last. In terms of treatments, some of the same treatments we talked about before. One thing that's done sometimes is something called mirror box therapy, where you basically see this is what this is showing you here. It's giving visual feedback of where that, that lost limb was, okay? Acupuncture, hypnosis, these all can help as well. There's also these types of prosthetics that are myoelectric prosthetics, so they're actually controlled by the electrical impulses from the patient's muscle contractions, and that helps to kind of sort of reset these types of sort of abnormal types of signals that are coming in, okay? All right. Another type of pain, sort of, syndrome or disorder, trigeminal neuralgia. And so this is severe chronic pain that affects particularly the trigeminal nerve. Where's the trigeminal nerve? It's right here, which I think makes it clear in terms of that the pain is facial pain, okay? So basically you get demyelination of the sensory fibers in the trigeminal nerve. Okay, so it's a sudden burning or shock-like attack, right? That's what this means, of facial pain, all right? In terms of treatment, maybe a surgical intervention might be necessary. Also, anticonvulsants. Again, anticonvulsants, remember, will decrease excitatory neurotransmitters or increase inhibitory neurotransmitters like GABA. All right, another one, shingles. Okay, so another name is postherpetic neuralgia or PHN, but this is shingles. We've probably heard of shingles before. And what happens is the patient has a reactivation of the varicella zoster virus, okay, VZV, when the immune system is suppressed. So usually, right, there's an initial infection, chickenpox infection, and then later on in life, that virus can sort of become reactivated. And it might be triggered by stress or some other type of stimuli. There is a vaccine, right, for shingles that is recommended for anyone over 60. Okay, so again, just a reminder, shingles itself is caused by this virus. Okay. Again, I'm reminding you that this is another word. Herpes zoster is another word for shingles. Okay. You basically end up with this painful unilateral rash. Okay. So with these this is this sort of what this is describing as vesicular eruptions in the dermatomes, okay? And so this is saying corresponding to the dorsal root ganglion that's harboring the virus. So meaning kind of it's along the spine here. And so this dorsal root ganglion is sort of exists right outside of the spinal cord. Again, I guess we don't really need to worry too much about that, but it's basically showing you that sort of rash and where that's coming from. And it can really, that rash really can end up in different parts of the body. I remember when my uncle had shingles, it was like around his eye, right? So it can end up in different spots. Antiviral medications, because again, this is caused by a virus, corticosteroids to decrease the inflammation. This again is the most common complication of shingles. So this is the sort of name for the pain part of the shingles, right? This burning, this itching pain. And it says periods of lancinating pain. So there is this really intense kind of sharp pain that happens. Okay. So the most common treatment, tricyclics, that are going to, alter levels, right, of norepinephrine and serotonin, and also dopamine. And so if you go back again, okay, post-herpetic neuralgia is really the pain syndrome part of this. Okay. So again, herpes zoster, another name for shingles. This post-herpetic neuralgia is the name for the painful part, the pain part of the shingles, okay? Which is obviously the kind of most, I mean, that's essentially what's going to be the major symptom that's going to affect the patient. All right, another type of pain syndrome, complex regional pain syndrome, right? Or CRPS. This is a neuropathic pain disorder. It usually affects one of the upper or lower limbs after injury or trauma, okay? And it's believed to be caused by dysfunction of both the peripheral nervous system and the central nervous system. It's probably kind of like, it's got to be one or the other. Probably most of the times it's both. You can divide it up into type 1 and type 2. So type 1 often occurs after fractures and dislocations, and that there's no detectable nerve trauma. If you talk about type 2, okay, there is injury to major peripheral nerves, okay, like a gunshot, okay, so you call that causalgia. So here it's kind of, there is no detectable nerve trauma, but you're seeing these pain symptoms, okay? What can happen during, and what's believed to kind of, one of the things that happens in CRPS is that if there's some injury to the nerve, right? So it just says we have this major injury to the peripheral nerve, it can cause basically something called emphatic crosstalk. So basically what's pictured here, okay? Here's your damage, right? Showing the myelin is sort of damaged here and basically lost. And it causes these, essentially these signals, the electrical activity to kind of jump this way instead of being transmitted down this axon. And basically what happens is start activating this neuron as well when it shouldn't be doing that. And so that's where the increased pain is coming from, the activation of this fiber from this adjacent neuron. Okay. The other thing is I just want to say about this is I know I have a girl that I know from high school, and her daughter has this, and I believe that she had a traumatic brain injury. And so I don't know if she only has pain in the head or what have you, but it doesn't only have to occur after a fracture or dislocation. I guess any really type of injury can lead to this, okay? And so this is saying here is sympathetic dystrophy. So there's another term. It's another term for this, reflex sympathetic dystrophy, okay? It's another name for type 1. But for whatever reason, there is, even here where it's saying there's no detectable nerve trauma, there must be some sort of dysfunction that's induced by that injury to the nerve, okay, that then leads to this. And so just as the name says, complex, okay? And the reason why it's called regional is because it's kind of, I guess, specific to sort of one area of the body. But like I said, I know my friend, her daughter had a traumatic brain injury and now has been diagnosed with this. So again, more complicated than it needs to be probably, right? So if we go a little bit more here, what are some of the clinical manifestations? So allodynia, talked about that already. Changes in blood flow, okay? Osteopenia and osteoporosis are actually another clinical manifestation, because we said it affects the mostly affecting the limbs, or it was induced by a fracture. And so basically in osteopenia, you start to see the bone density dwindle. Osteoporosis is more serious, okay? Abnormal sensory perception of that affected limb. In CRPS2, severe burning, crushing, or stabbing pain. And like I said, I guess I don't know if it's categorized as another type of CRPS, but like I said, I've heard of the situation where a traumatic brain injury can sort of induce this as well. In terms of diagnosis, right? It says positive response to a sympathetic block, meaning if they block this sympathetic nerve that's coming out of the spinal cord here, by injecting some sort of anesthetic into the nerve, right? Basically, if it shows that there's a reduction in pain, improvement in motor function, etc., it indicates that it's this complex regional pain syndrome. Okay, so that's one of the ways that they diagnose this. Okay, in terms of treatments, very similar to what we mentioned before, okay? Mentions here peripheral nerve block. It's kind of the same idea here, right? If you're going to block the activity of a nerve, that's going to then help with the pain, right? Because we were talking about these nociceptors detecting the pain and then transducing and sending that signal into the spinal cord. Well, if you block that transmission into the central nervous system, it can help with the pain, okay? Physical therapy, TENS unit, we talked about that before as well, okay? All right. Last section, I believe, is on headaches. Okay. So some different types of headaches here to mention. Tension type headache, most common. Okay. Also called pericranial myofascial pain, because you can see where that tension type headache, where the pain, is localized. Okay. So you get this excessive contraction of these muscles that are underneath the scalp here, kind of, on the sort of base of the skull, right, at the top of the neck, right? That's what it's saying. It could be caused by inflammation, right? Again, or excessive contraction of those muscles, ischemia, emotional stress, inadequate rest, poor posture. These all contribute to that sort of, inflammation that might get in there, or that increased contraction that might occur and lead to that tension type headache. Clinical manifestations, right? Constant, bilateral, dull, non-throbbing, sort of band-like pain around the head. We've probably all experienced one of these before. Treatment, aspirin, acetaminophen, or, ibuprofen and things like that. All right, talk about migraine headache, right? And again, some of us may have experienced, some of the things we've talked about through this chapter. Chronic, complex, believed to be, involve the vascular system, right? Neurovascular disorder, it says here. Genetics definitely contribute to it. There are certain triggers for different people, right? Could be dietary, hormonal changes, environmental factors, increase in stress, change in sleep patterns. These all can trigger a migraine, okay? Sorry, why is my arrow not working? If we talk about clinical manifestations, right? Throbbing or pulsatile unilateral headache usually can also be accompanied by nausea and vomiting, sensitivity to light and sound. There's also something called an aura, where you have some sort of change in perception that actually might occur before that migraine. Could be visual, could be olfactory, etc. Okay, so that's something that's sort of characteristic to a migraine. In terms of diagnosis, there is specific diagnostic criteria to diagnose migraines versus another type of headache. The fact that it's unilateral, this pulsatile nature that we talked about, the severity of the pain, if it's aggravated by physical activity or not, the presence of nausea or vomiting. So important to sort of consider all these things when diagnosing it as a migraine or not. There are therapies that patients can take just sort of regularly to prevent the onset of a migraine. Botox is used, tricyclics, anticonvulsants. Those are all used. In terms of acute, right? You can use an ibuprofen maybe or some other type of analgesic, basically once that migraine occurs. Okay. We talk about cluster headache, least common type. Unilateral severe pain. It's associated with ipsilateral cranial autonomic symptoms. Okay. And so when we talk about autonomic system, right, we're talking about the sympathetic and the parasympathetic nervous system, believed to originate in the hypothalamus, right, and actually through that trigeminal nerve. And I showed you a picture of that trigeminal nerve before. Clinical manifestations. Oh no, was that? Wait, am I misspeaking? Yeah, okay. Right? Just reminder. Trigeminal nerve. Yeah? All right. Sorry. Clinical manifestations, sudden onset, right? Severe, piercing unilateral pain that's located behind or around the eye. Again, if you think about the location of that trigeminal nerve. What are some treatments? Subcutaneous or nasal serotonin receptor agonists, because again, all these treatments we've been talking about, some of them, right, they increase serotonin. Okay, so this helps with this type of headache. There's also another type of molecule here that can help widen blood vessels. Okay, oxygen and also other types of nerve blocks can help with that as well. All right. We're just about done. So some other pain syndromes that exist: central pain syndrome, CPS, result from central nervous system damage or dysfunction, can be caused by stroke, MS, or head trauma. So like I said, I mentioned my friend. I know that her diagnosis is the CRPS, but there must be sort of overlapping terminology with central pain syndrome and that CRPS, right? Remember we mentioned this here. Just like I said, from experience, there must be, like I said, maybe kind of CRPS and CPS are sort of used interchangeably. Okay. Pain most severe in the hand and the feet. Again, what are some treatments? Opioids, antidepressants, deep brain stimulation is another one. And we talk about myofascial pain syndrome. If you talk about the fascia, right? It's basically showing you kind of this, where the trigger point is and then where the referred pain is. So deep muscle tenderness or hyperirritability and this referred pain pattern. Okay. Muscle relaxants, physical therapy. These all can help with this because again, it's originating the fascia that sort of, covers the muscles, and that's where it's originating from. Okay. Fibromyalgia, this is, and we've probably heard of this before, chronic widespread pain that lasts longer than 3 months. So this is really widespread, and I think that's maybe what makes it a little bit different than some of the pain syndromes we were talking about before. Okay. So this is pointing out this picture, these 18 symmetric tender points that you see in fibromyalgia. It says here central sensitization. So it's believed to arise from some sort of sensitization within the spinal cord of the brain, right? And when we talk about sensitization, we're saying that that neuron or those neurons that are going to transmit pain are becoming more active. Okay. So it says diagnosis of exclusion, meaning if you go through kind of all these other types of pain syndromes and you really can't, you're not diagnosing anything else, oftentimes it's going to be then diagnosed as fibromyalgia. Treatments, again, pretty much very similar to what we talked about before. SSRIs, anticonvulsants, right? Other antidepressants, opioids sometimes are used to treat this, but again, we want to use opioids as a last resort to treat any of these pain syndromes that we're talking about. Physical therapy, even cognitive behavioral therapy, okay, acupuncture, right? Biofeedback, massage therapy. Because again, remember that pain and the perception of pain is complex, right? It involves cognition. It involves, we talked about with anxiety and depression, right? And we talked about a lot of those brain areas that we talked about in that chapter are going to come into play here because they will sort of feed into some of these pain pathways. Okay, so very complex in terms of actually how that pain is perceived by the patient. Okay, and again, something that's really important to understand clinically when you're treating patients, and and to really think about the patient's situation, right? What's going on in their life and how this might affect their perception of pain. Okay, and so that leads us to kind of think about this a little bit more, right? Psychogenic pain. So central nervous system dysfunction influenced by psychological factors. And that's really what I was just kind of talking about, right? That really anything that's going to interfere with, function of some brain area can ultimately then affect pain perception because there's lots and lots of interplay between these different brain areas. And so, like I said, some of those brain areas that we talked about before are going to come into play here. Same treatments, right? Again, we're not going to want to treat with opiates in this case because that's not a good idea. Like I said, in general, we use opioids as a last resort. Another type of pain syndrome here, persistent post-surgical pain. So this is, again, specifically after a surgical procedure, but it's going to persist for 2 or plus more months. In terms of preventative strategies, regional anesthesia, interoperative NMDA receptor antagonists. And again, this is the idea of trying to deactivate these neurons that are going to bring pain signals in, okay? Treatment, analgesics, okay? Nerve blocks like we talked about before. Even ketamine or gabapentin. Gabapentin, again, is a drug that's going to, work at the GABA receptor and basically increase the activity of GABA, which is inhibitory, okay? And that ends that there. Again, I'm not going to be asking you about specific treatments for these diseases or anything like that. I think we want to just understand in general kind of what types of drugs are used to treat pain. And because there was lots of overlap as we went through, okay? And that ends that, guys. So make sure you take a look at that review sheet and complete those notes there. Thanks.